So can we please have Dr. P. Mahesh Shanmugam sir to please give his oration lecture in the name of Dr. Namperumalsamy sir. Thank you.
Morning and thank you. Can I have my slides? It's truly an honor to receive an award in Dr. Namperumalsamy's name, the pioneer who started vitrectomy in India. And I wouldn't be standing here as a vitreoretinal surgeon if not for Dr. Chief, who was the one who guided me to taking up vitreoretinal surgery. And I am where I am thanks to my teachers, Dr. Gopal, Dr. Chandan Abraham, Dr. Tarun Sharma, and also the continued support of Dr. Ramani and Dr. Janaki Raman. This is version 2 of the, and then there is hope. The version 1 was presented in Vitreoretinal Society of India last year. So vitreoretinal surgeons are a hopeful bunch. So we are always hopeful. So we keep hoping that this retina which we attach will keep remaining attached and that patient with the recurrent vitreous hemorrhage doesn't keep recurring. And of course, we also hope that the patient with multiple recurrences goes and finds another doctor and leaves us alone in peace. So we do offer hope to our patients as well as to our colleagues. And this oration will be looking at just stories of hope. So this is a 24-year-old newlywed young gentleman whose wife was threatening with divorce because he had this mass lesion on the nasal side, which is continuing to grow. He had a vision of 6/6, and the fact that the lesion was growing, continues to grow, we did a biopsy, and it showed an extremely rare ancient intraocular schwannoma. It is a suprachoroidal tumor, and the fact it was growing, we decided to remove it. So we did a hinge flap of a full thickness sclera, and you can see the grape-like uvea, which is prolapsing out, and very carefully the sclera was resected off the uvea. And we see this mass lesion in the suprachoroidal space. So that is the schwannoma, what we see here. So it was very carefully dissected off from the uvea and from the overlying sclera. So we used an endocrine probe to hold on to the mass and removed it without rupturing the uvea. So the mass was removed and the flap was closed. In the process, the incision biopsy site opened up, which is also closed. So he continues to retain his eyes. Of course, he didn't go through with the divorce, and he continues to have a 20/20 vision. So this is a Yemeni war victim. He doesn't have arms below his shoulders and no legs below his hip. And he was bilaterally blind. One eye had been eviscerated. The other eye was tricycle with Simplifron. So this was how it was when we released the Simplifron. She opened up the cornea and dissected the fibrous tissue and scar tissue in the anterior segment. So quite a significant scarring was there. We removed the iris and dissected the scar tissue, used viscoelastic quite liberally. And as we are dissecting the scar tissue, something happened. You can see now the retina prolapsed out. So I thought, okay, we had lost the eye. But then we decided to go ahead with the surgery, put the retina back with viscoelastic, and placed a temporary keratoprosthesis and went inside. And to our relief, we found that the retina was still attached to the optic nerve head, but of course it was a closed funnel detachment. And we removed all the subretinal gliotic membranes and the preretinal gliotic membranes, and painstakingly opened up the funnel, which was torn from the ora serrata at 360 degrees. Took some effort to open up the retina, and finally we put up perfluorocarbon liquid. You can see the retina attaching, you can see the disc. There is a peripapillary fold, but then whatever retina was there can be attached. So the retina was stretched, and the laser photocoagulation was done to the peripheral margins. He is ambulant now, but of course at least one of his eyes is functioning, though he doesn't have legs and arms. So this was a bilaterally blind 5-year-old child, a very close friend of mine who is a top-class ROP surgeon in the country, had operated the right eye. And this eye was lost despite the lensectomy, vitrectomy, and the other eye, the primary surgeon declined to operate. Me, being the fool I am, even today, because the parent continued to pressurize me, succumbed to the pressure and took it up a surgery. And inside, this is what we found. You can't make out which is the retina, which is the fibrous tissue. Nothing could be made out. So we very painstakingly removed all this fibrous tissue. And that yellow pigment, what we see is what we think it's the macula. Nothing more could be seen. And there's a stage 5 ROP, and this child is 5-year-old. So we decided to leave it alone like this because essentially a traction retinal detachment after removing all the scar tissue, hoping that the retina may attach and the child may get some vision. But then about a month later, there was vitreous hemorrhage, and we went back inside and found this multiple retinal holes in the periphery. But the positive side was we could see the optic nerve head now. You can see the optic nerve and the macula. So some of the pre-retinal tissue was removed and did a fluid R exchange to see what's happening. You can see the posterior pole is going back. You can see the disc in the macula now, but the peripheral retina is still stretched taut because of the contracted retina. So ultimately, had to do a 360-degree relaxing retinectomy, relieving the posterior pole from the retina, which is pulling up the periphery, and attaching the posterior retina. Of course, it looks like a map of Sri Lanka, the retina which is left over, but at least some Sri Lanka which is seeing. So we managed to attach the retina, and they did laser photocoagulation. Is the child seeing? Yes, the child's vision has improved to count fingers 1 meter, but the problem is, for the last 5 years, he's been feeling his way around. So even today, he's keeping his eyes closed and feeling his way around. So if you open his eye, he's having about count fingers at 1 meter vision. So this is where we started, and this is where we ended with this child. Pediatric retinal detachment, the onus is on us, the burden of lifelong blindness. A very small mistake you do, a small break in an ROP surgery, you know that this child is not going to see forever. This is one such. The other eye was lost, and this eye had a stage 5 ROP, closed funnel with a corneal opacity. We removed the cornea, removed the calcific lens, and the age-old surgery of an open sky vitrectomy is what is being done here. So the fibrous tissue causing the traction retinal detachment is being relieved, and that's the retina what we see here. Closed it up with the viscoelastic and the penetrating calcoplastic. It's like really with gratitude that you can see this child moving around after this surgery. This was a 2-month-old boy who has a family history of retinoblastoma. Left eye was enucleated at the age of 1 month, and the other eye was also advanced enucleation. Group E retinoblastoma. So we did intravenous chemotherapy, local treatment, tumor regressed. But then at the age of 18 months, he underwent scleral buckling for recommended retinal detachment. At 4 years, lens aspiration, 5 years, IOL. 7 years, he had a recurrent retinal detachment. So this time we did a vitrectomy. There's a triamcinolone stained vitreous which is being removed. And the break was somewhere here in the superior temporal quad and somewhere underneath this calcium. So we did a drainage retinotomy, reattached the retina, did laser photocoagulation around the calcium, hoping that it will remain attached, and used the oil. The retinal detachment persisted 4 months later. That the calcium in the superior temporal quadrant was keeping the break lifted. So we thought, okay, we'll support it from outside. So we removed the old buckle and put a macular buckle, hoping to push that calcium up and close the break which is underneath that. We did that, but instead of making it better, it made it worse. The calcium lifted up further, and the break continued to remain lifted. A relaxing retinectomy was not possible because if we did the relaxing retinectomy, then the only functioning retina would be cut off from the optic nerve head. So in desperation, we went ahead and tried cutting that calcium, hoping that tumor which is lifted up will fall back and the break will fall back. So we dissected that calcium, allowed the that part of the calcium to sit back, and did laser photocoagulation and put silicon oil. And this was how it was immediate post-operatively. Then 2 months later, the fluid decreased, then decreased, and now it's attached. And he's a strapping young lad of 16 years and continuing to see well. So this was a last story. A left eye was a macula-on retinal detachment, had undergone surgery elsewhere with vitrectomy and silicon oil injection. The patient presented to the primary surgeon with headache 1 week post-op and presented vision loss in the right eye, which was a normal eye. And when we did the visual fields, we found that a hemianopia in the right eye. And an MRI showed what had happened was the silicon oil in the left eye had migrated into the chiasm and caused hemianopia. So this is the once-in-a-lifetime silicon oil removal which is being done. A patient underwent craniotomy. Then optic chiasm was opened and the silicon oil is being removed. Of course, it's not by me. It's with my colleague, neurosurgeon friend of mine. But of course, I was there to direct this surgery. So that's what you see is the optic chiasm from where the oil is being removed. And this is the field defect which has resolved after the silicon oil removal. Grateful acknowledgement to all my colleagues as well as my staff, without whom all this wouldn't have been possible. And of course, my family for standing by me always. So blessed to be a VI specialist offering hope. Thank you for your kind attention.
Thank you so much, sir. I think it was such an amazing oration, and thank you for all the pioneering work that you have done, especially for our